Well, many patients who come for consultation, a very common issue is the pain that's associated with the wall procedure. And I thank Cheyenne and the other organizers of this conference that enabled me to present my experience with this issue. Well, while performing while the patient is awake, comfortable and relaxed, is that an oxymoron, or is it possible? What is pain? Pain is basically a subjective experience consisting of physiological and psychological in response to noxious stimuli. In a simple way, it is action and reaction, we can say. It's the unpleasant sensation that brings about some reaction, like moving the hand away. But it's actually more complicated. There are 4 parts to the process of pain: the transduction, transmission, modulation, and perception. The transduction is basically when we apply this unpleasant stimulation to the skin or wherever it happens. It can be mechanical, it can be chemical, it can be thermal, and that results in release of some chemical mediators from these receptors. These chemical mediators stimulate peripheral nerve that bring the stimulation to the spinal cord. And along the spinal cord, it brings another set of neurons bring it up to the midbrain, and finally from the midbrain to the cortex. But that's not so simple, and actually in our favor is what we call the spontaneous analgesia, because when the stimulation arrives to the midbrain, it also stimulates some downward neurons that modulate or can suppress the upward pain stimulation. They do it through different neurotransmitters, that acts like opiates, and one of the ones that everybody knows about is the endorphins that makes the pain easier. The final part of the pain transmission is when it becomes conscious experience, or the perception of pain. And there are 4 kinds of perception. First of all, we are aware that we were kicked in the back. So that's the sensory part. Then it stimulates some reaction. We move away. Then it affects our mood. And finally, it affects how we're going to behave in the future when we see a similar situation. Please differentiate between pain threshold and pain tolerance. The threshold is when a certain experience or certain sensation becomes painful. For example, we put our hand on a plate and we start to heat it. First it feels warm, then some faint pain. At a temperature of 48 or so, we start to feel pain. That's different from the tolerance, which is basically when the pain becomes a suffering, unpleasant experience, and that's different. Women tolerate pain better than men. It's a matter of culture, experience, occupation. Many factors affect the tolerance. The last point about the physiology of pain is just to be aware that the pain can be amplified by the sympathetic system. So when we're on the edge or we're excited, the pain is amplified. Stress, fatigue, worry, anxiety, all amplify the pain. How we control pain? First, we have to differentiate between analgesia, which is lack of relief of pain. And then we do it, many of us, almost daily by taking some Advil or sometimes Percocet or whatever. We are fully awake. Maybe there's some side effects, but we are fully awake. That's different from anesthesia. And there are 4 types, basically, levels of anesthesia. The first one is general anesthesia, when the patient is totally out, unconscious, immobile, relaxed. There's no muscle tension. It takes expertise to provide it because you have to control the airway. And the only communication between the patient and the providers is basically through these monitors that give the heart rate and the vital signs. That's a regional anesthesia that is applied to from a certain level of the body down, like epidural. There's the conscious sedation, IV sedation, or the twilight anesthesia, when we give medication, so the patient basically asleep, unconscious, but still can control the airway. And then there's a local anesthesia. Why I believe that local is preferable when we do perform the wall procedure. First, I would like the patient to be fully awake. I would like the patient to be able to move. And I like the patient to be able to warn me as a surgeon if she feels anything. Second reason is that, in my opinion, general anesthesia or regional or whatever, it's an overkill. It's an unnecessary. And I hope that I'll be able to present to prove my statement. Now, local anesthetics are not without risk. Besides the local manifestation, there's a systemic toxicity. It's very rare, 0.03%, but they are real. One category is the central nervous system complication, which can be just numbness, but can develop to seizure. Most serious are the cardiovascular complications, can be just arrhythmia, but can develop to total cardiovascular collapse. These are four of probably most common local anesthetics that use in the US. So lidocaine, everybody knows about lidocaine. It's very cheap. It's short-acting, short onset time, but it is less safe. Now, if you see, there's the CC-CNS ratio, which is cardiac complication to CNS, central nervous system complication. What it makes it less safe is you can have CNS signs of toxicity, and the cardiac toxicity will come shortly afterwards. On the other hand, carbocaine or mepivacaine, they are also short-acting, short duration, but if the patient feels some tingling in the tongue, for example, there's enough time to address it and to avoid cardiac complication. Bupivacaine is a very commonly used local anesthetic in the US. It's just long-acting, but it's a very effective, but it is less safe compared to naropin or ropivacaine, which are long-acting, but much safer and much less complication, CNS and cardiac complications. Let's think, what our optimal local anesthesia? We want to use the smallest dose that will provide the desirable analgesia and anesthesia, and we want to use the safest medication. Our choice is carbocaine and ropivacaine. They're much more expensive. For example, ropivacaine is about 10 times more expensive than lidocaine, but we still like it because it's safer. That's our goal. We start from the picture on the left. That's what we start with. We want to take what we see on the right, and we want to do it while the patient is awake, relaxed, and comfortable. So the day before surgery, what we are doing, we try 3 different of local anesthetics, and 3 combination of the 3. We inject it underneath the skin, and we wait a little bit, and we use a needle prick or pinching, and we check which one gives us the best local anesthetic effect. So that gives us already a big assurance to the patient that we are going to use something that will be effective. Now, the night before, we also review the procedure in details so patient will know what to expect, less anxiety. We tell her what we're going to do in case she feels pain. And we make sure she gets a good night's sleep. All this to suppress or modulate the transmission of pain. At the day of surgery, we just give 2 things consistently: anticoagulation an antibiotic. Some patients ask for some Xanax or Percocet. Many don't care about that. First, we put local anesthetics just locally to make the small cuts for the access of the cannula. I'm using the water jet lipectomy or wall procedure that I learned from Dr. Stutz, and I like this procedure. I do not use tumescent for lipedema patients for a variety of reasons that I'll not discuss now. The water jet basically works like it's a jet of water, and there's one part for the first part of the procedure, the infiltration to numb the area, and the second part to irrigate the fat out. This is very important. It's a busy slide, but it's very important for me. On the left side, you see the first, until about half a year ago, these are the solutions that we use. We used for the infiltration 45 milliliter of ropivacaine, the same amount for carbocaine, and 1/3 of that for ropivacaine for irrigation. At that point, we had a patient that in the middle of the irrigation, he became confused, disoriented, almost like delirium. We tried to investigate what is the issue. We spoke with pharmacists, with the anesthesiologists, and finally we decided that let's eliminate all the local anesthetics from the irrigation. Or from that point on, we just use the same solution for infiltration, but no local anesthetic for the irrigation. Zero, just water. So the volume that we use is the same for the procedure, but the amount of local anesthetics is cut by 1/2, both ropivacaine and carbocaine. And you see, there's no more pain. You see on the monitor, the heart rate is 65, good oxygenation, patients feel comfortable. Why I like it? Because it's safer. You're using 50% less local anesthetic. Since then, we did not have any patient who experienced nausea during the procedure. There's much less orthostatic hemodynamic changes. In other words, the blood pressure does not drop when they get up, much less lightheadedness, less headache. Why also I like it? Because the patient can move during the procedure. She can turn around when I ask her, turn to the right, turn to the left. She can flip the foot up and down, all that to avoid DVT. She ambulates faster. Patients walk out of the office in about 1.5 to 2 hours and walk to the car. I don't like the patient to be passive during surgery. I like the patient to be an active participant in surgery. I like to get all the time, I like to get feedback for the patient. It's very invaluable for me. And why? Because pain, as much as we all hate pain, this is our most important protector from injury or damage, and surgeon can damage. And if the patient, whatever the patient, feels something, if she feels, she said, I feel something, first, I make sure that it's not my fault, because if the cannula that you use, it's not at the right angle, not just in the right plane underneath the skin, patient will feel pain. So I immediately correct myself before I can cause any damage. And when you do the belly, for example, it's very important. Another possibility is some of the patients feel anxious or tense, so then we give nitrous oxide. If still there's pain, we can infiltrate with the numbing solution for a few seconds, the area that numb, and it solves the problem. What else can we do? Well, that's a laughing gas of nitrous oxide. It's 50-50%. We give maybe 5 or 6 inhalations. That solves the anxiety. It doesn't take the pain away, it takes the anxiety, but it modulates the perception of pain. What else can we do? A lot of TLC. I don't know what Shimi, our nurse, is doing with the patient while I'm getting the fat out, you see in the tubing. I don't know, joking or patting her head, whatever, but she had to keep her comfortable. Drinking, snacking, jogging during the procedure, very helpful. That always makes the patient feel good. If you see the left side, you see when I pinch the skin on the left, like before it was done, and on the right side, after it was done. Patients are happy to see that. That makes her feel good. And of course, to see the bag of the fat in front of her, that she loves that. And finally, good, engaging, inspiring, relaxing music. It's always helpful. We hate the elevator music that I think it's annoying, but something like, and here I quoted the anthem, a song by Leonard Cohen, and I think this sentence is very significant to each of us. There's a crack in everything. That's how the light gets in. Thank you.